and good evening. My name is Nikki Mitten, and I would like to give you all a warm welcome to today's webinar hosted by Colgate Professional. Our subject today is a silent pain, what patients do not talk about, with Giulio Pavalucci. Before we get started, we have a few housekeeping items that I would like to take you through. My colleague Suzanne from WebEx is here in the background to make this process go as smoothly as possible from a technical point of view. If, however, you do experience any technical difficulties during the WebEx session, please dial our UK toll-free number on 0800 389 9772, or you can message Suzanne using the Q&A panel. I would like to emphasise that Colgate's webinars are all about sharing knowledge and experience. We want to hear from as many of you as possible in the Q&A session after the presentation. You may ask an online question at any time during this presentation by simply clicking on the QA panel located in the lower right of your screen. Type into the text field and press send. Your questions will not be seen by any other members of the audience, and you will be addressed time permitting towards the end of the session. Another small but important point, you will all receive 1 hour verifiable CPD for all UK participants joining this webinar, and the first 250 participants that joined this webinar this evening will receive a free preclinical C350 electric toothbrush, but only if you complete a short survey at the end of the webinar. Please note that this survey will pop up when you close the webinar screen, and it will also be sent to you via email following the webinar this evening. Please complete this survey and submit it. And once we have received your answers, you will receive your CPD certificate via email. And if you qualify, a brush will be delivered to you within 28 days. The aim of this webinar is to give an overview on how you can help relive your patients from the pain of dentine hypersensitivity to improve their quality of life and patient satisfaction. The learning outcomes are to review the available chairside clues to aid proactive dialogue with your dentine hypersensitivity patients, to understand how to introduce assessment and management plans for dentine hypersensitivity sufferers, and how to apply essential teamwork between dentists and the wider dental team to benefit both the patient and the practice. I would now like to hand you over to today's speaker, Dr. Giulio Pavalucci.
Hi, everybody. Thanks, Nikki, for the nice introduction. Thanks, Colgate, for the invitation, and thank you all for being here. So I'm in my home in Italy, and it's really amazing to speak with you. I'm really happy to talk about this topic because dentine hypersensitivity is something I strongly believe it's really important in our practice. And now we are going to talk about dentine hypersensitivity, but not in the classic way. We will not talk just about diagnosis and therapy, but we will try to focus on the patient point of view. Why? Because it's really important. It's really important because most of the time, patients do not talk about this kind of problem. Maybe because they're just a little bit shy, or maybe because they don't think that this is a great problem, or maybe because they just think that the dentist is the doctor of filling and just period treatment. So they really do not understand that this is a real problem. Or maybe we, as clinicians, we do not understand that dentine hypersensitivity can be a real problem. So what is dentine hypersensitivity? By definition, is a short and sharp pain, and this is really important to make the correct diagnosis, that is derived from exposed dentine in response to chemical, thermal, tactile, or osmotic stimuli. And another thing that's really important, which cannot be ascribed to any other dental defect or disease. And this is essential for a correct differential diagnosis. So we will see later on how this is really crucial. Dentine hypersensitivity can be a real problem for the patient, but also for us, because it's a sort of vicious circle. Maybe you have low oral hygiene on our patients, so they can have gingival recession. This can lead to exposed dentine, and this can lead to hypersensitivity. which leads once again to lower oral hygiene and so on and on. It can be really painful for the patient and a real problem for us to manage simple daily practice in dentistry, in everyday dentistry. So this is the first polling question that I'm going to make you, and you will have the chance to answer. You will see the answer on the right of your screen, so just click on the answer that you think is correct, and then click Submit on the button. There is a button. So the question is, what prevalence of dentine hypersensitivity do you see in your patient base? Answer A, up to 10%, B, between 20 to 35%, C, between 35 to 57%, D, over 57. So please choose your answer and then click on Submit. So we now have to wait a little bit. So you have some seconds to choose your favorite answer, and then they will give us the result. So I'm submitting my answer too. So the poll has ended. Now we have to wait for the result. Let's see what happened. This is really important for me because, of course, I know the data from literature, but as we will see later on, data from literature must be understood, and we have to read properly the data. So here are the answers. A, 5%, B, 22%, C, 46%, and this is the winner, D, 15%. And I agree with you. I totally agree with you because we will see later on the data from literature. So we will see that dentine hypersensitivity is an underestimated problem. Oh, just a thing I forgot. You have to switch on clicking the participant icon on the top and right just to see, again, my face, if you want to see my face, of course. So coming back to our topic, dentine hypersensitivity is really an underestimated problem. We should listen to our patients. We should try always to make the correct and complete diagnosis. And we have to explain the problem. But even more, we have to understand the patient because most of the time patients are not telling the whole truth. So patients need to understand. Let's see what literature says. We have studies reporting different data. Prevalence varying from 4.5% up to 57%, depending upon the population, the criteria used to assess sensitivity. So we have really to carefully read literature, and we have to understand how the study was conducted. But believe me, dentine hypersensitivity is really diffuse, and DHS prevalence will increase in the future. And this is really simple to understand because we are putting continuing emphasis on preventive dentistry, and this is good, of course. But it means that more and more adults will keep their teeth in advanced age, so we will have much more chance to have this teeth hypersensitive. And we will have an increased number of exposed dentine because we are having an increased number of risk factors, and we will see it later on the slides. The incidence, we have dentine hypersensitivity in almost every age, but of course we have an incidence, and this is especially in the range between 20 and 40 years, and we have a higher incidence on female subjects. The epidemiology, we have the dentine hypersensitivity spread all over the world. But once again, in this study, we can see that females are most affected than men. And patients react most of the time to the cold stimulus. It's really the most painful in most of the cases, then the tactile stimulus, and then the osmotic. And later on, we will see why every one of these stimulus can cause the pain. And the most affected teeth are the premolars with a 38%, followed by incisors, 26, canines, 25, and molars, 12. Why do we have this pain? All of you, of course, know perfectly the hydrodynamic theory that is the most accepted and diffused between all the theories that are trying to explain dental pain. At first, we have to say this is just a theory because for obvious ethical reasons, we are not really able to conduct the perfect study to understand this theory. But it's most likely the correct one. So the theory says that dentine hypersensitivity and all the dental pain occurs when an external stimulus contacts the exposed dentine, and this can trigger a change in the flow of dentinal fluid. And it's this change in the flow of dentinal fluids that excites baroreceptors and leads to the pain, to the neural discharge. So we have not a real nerve in the dentin surface, but it's all about the movement of the fluid inside the tubules. Which are these stimuli? The thermal ones, and they are two, the hot and the cold. The hot stimulus it usually causes less intense pain because it provokes slow fluid displacement toward the dentinal organ, so the movement is centripetal. On the other hand, the cold stimulus can cause a movement that is centrifugal, so it's toward the stimulus. And this pain is usually rapid and intense. And maybe you also have tried this kind of pain because, as we said, dentin hypersensitivity is really diffused and also between the dentists. Then we can have the osmotic stimulus. And this is really important to make differential diagnosis because it's really common in a tooth with a caries. So the osmotic stimulus is not very intense, but it can last long, and it causes a centrifugal movement, just like the cold one. The evaporative stimulus, and we can simulate it with the normal air blast in our chair, in our office, once again, is a centrifugal movement, and the pain can be really high, and is, of course, proportional to the higher intensity. Let's have a look to the etiology of the dentin hypersensitivity. Of course, we said that the main cause is that we have exposed dentine, the tubules can be open, and so we have this movement on the fluids inside the tubules. But why do we have this exposure of dentin? Dentin shouldn't be exposed to the oral environment. We can have the gingival recession. We can have lots of enamel or cementum, so lots of hard tissue. Or we can have the veneer layer removal, or maybe we can have a bleaching treatment. Let's have a look on the gingival recession. All of us, we see a lot of recessions, maybe even little ones, but they are really common in our daily practice. Why can we have gingival recessions? Maybe for incorrect brushing technique. This is very important. Every time that we see this kind of lesion on the soft tissue, always give a toothbrush and a mirror to the patient and test them. Let's have a look how they brush their teeth. We'll see later on we have the correct technique, the correct toothbrush, and we have to teach them. If nobody teaches how to brush their teeth, they will do it in a not correct way, and they will damage the soft tissues. Maybe we can have acute or chronic gingivitis, or maybe even periodontitis. From 60 to 98% of patients suffering from hypersensitivity, patient with periodontitis. So it's really a strong problem. Or maybe even the treatment. We will see later on a lot of periodontal treatment can have dentin hypersensitivity as a collateral effect. So we must know it, and we must tell it to our patient. Or maybe it's just a simple aging process. Patients get older, and as we said a couple of minutes ago, we can have much more chances to have patients with all of their teeth in the mouth, even in advanced age. Or maybe it can be the reaction for surgery. Just think about the surgical crown lengthening technique. We have an apically repositioned flap. So our aim is to produce an artificial recession because we want to erase the pocket. So we want to make the patient heal from his problem, but we are generating a recession. Or maybe we have a chronic trauma due to incorrect habits. So as we said, both periodontal disease and some of the treatment procedures can involve a remodeling of the support tissues of the tooth. And this can lead to an apical shift of gingival margin, and this is really often associated with root sensitivity. So once again, we have to tell it before to the patient, because every problem that can occur, if I tell it before, is an explanation and explain the future problem to the patient. If I'm telling it after the problem comes, this is just an excuse. So we will lose a little bit the confidence from the patient. So let's have a look to other possible causes of the dentine hypersensitivity. As we said before, we can also have the loss of the hard tissue. So we can have loss of both enamel and dentin because of the attrition, because of the abrasion or the erosion. And the difference is quite easy to understand. Attrition is made by tooth-to-tooth contact. So if you take a look on the picture on the upper left, you can easily understand that it's attrition because you can see the perfect matching between the upper and the lower teeth. We can have abrasion that is caused by mechanical forces from a foreign element. So it's not something originating inside the mouth from tooth-to-tooth contact. Or we can have erosion. Erosion is chemical. So we have acid that is destroying our teeth, but it's not the acid from the bacteria, so it's not caries. Erosion is really important. Nowadays, it's really diffused, and we have to understand it, and we have to see the first signs of the erosion because we have to tell it to our patient, and we have to try to fix and to remove all the risk factors. So, which can be the causes of the erosions? We can have extrinsic reason or intrinsic ones. The extrinsic are coming from outside, so most of all, food and beverages. So maybe acid drinks, some juices, some alcoholic beverages. The energy drinks are really underestimated. They're really acidic, so really dangerous for our teeth. And some infusion also. Or maybe we can have intrinsic factor, so it's the acid coming from the stomach, so the gastric juices. And the causes can be more than one: hiatal hernia, GERD, chronic alcoholism, or the eating disorders that are really, really diffused in young patients. Let's try to understand the differences between attrition and erosion in science. So how to understand if you are facing a case of attrition, erosion, or a combination of the two. And pay attention, we have a lot of time the combination of the two, attrition and erosion. If we have attrition, pure attrition can have sharp and shiny facets. So it's easy to understand, it's easy to see, and compare the facets on the lower arch with the other on the upper arch, and we have to find a matching. If we have erosion, we have this volcano-shaped lesion. They are saturnine, opaque, they're smooth. So it's easy, really easy to understand the difference. If you see the picture on the center and you see these big holes, they're out of the occlusion. So it cannot be attrition. Maybe like in the picture on the bottom right, you can see that we can have both attrition and erosion. So we can see the lesion caused by the movement of the opposite arch, but you can also see this volcano-shaped lesion. And this is really important because, of course, it's easy to see the erosion on the picture on the right because it's really big, it's huge. But when you see a premolar, like the one on the central image, and you see this really, really small hole, a really small concavity on the dentine, you suddenly have to think about acidity. So try in this very moment to ask the patient, do you have any problem with, I don't know, gastritis? Do you suffer from hiatal hernia? Do you drink a lot of energy drinks, sodas, and so on? Because we really have to understand that it's important to make the diagnosis as soon as we can before the patient loses his dental structure. Let's have a look to the GERD, gastroesophageal reflux disease. We have usually erosion on palatal surfaces, on all the upper teeth, and occlusal surfaces or lower molar. And this is easy to understand because the direction of the acid goes inside the mouth, from inside the mouth, directly to the palatal surfaces of the upper teeth. Then this acidic environment will make the acid stay and lie on the occlusal surface of the lower teeth. So you will see these typical images, and you have to understand, and you have to inform the patient because most of the time GERD is non-symptomatic at all. So you have to suggest the patient to see his doctor and to talk about this problem and to investigate deeper. And remember that the GERD can be a potential precursor of Barrett's esophagus, which can lead to the cancer. So we have to pay a lot of attention. Let's talk about the other common cause of erosion, the eating disorders, bulimia, for example. In case of bulimia, we have a typical erosion, and this is spread on all palatal surface of the upper teeth. And beware, and the erosion of the upper teeth is significantly higher than in the lower. That's why, because the tongue is kind of protecting the lower teeth during the vomiting moment. So it's really easy to identify this kind of patient. And of course, we have to help this patient, not only thinking about the teeth. In this kind of patient, teeth maybe are the last problem. We have to talk to them, understand which is the problem, and remember that we often have very young patients, teenagers. So we have to find the right way to talk to them, maybe ask for help to a psychologist, to the parents, because it's really our responsibility to understand the signs of this kind of huge problem. Let's have a look at this patient. When she was 22, she was complaining for a lot of dentine hypersensitivity. She told me that she was not able to breathe without having pain. And so she went to her dentist. And she went to her dentist, complained about this problem, and of course, at the age of 22, she already had a lot of signs of erosion. So I think, I'm imagining that it was quite easy to understand the reason of the pain. But the solution for the first dentist was quite simple: 20 root canal treatments and 6 porcelain veneers. So you're complaining about the pain, no pulp, no pain, problem solved. And this is really bad. This is really a pity, because now she's more than 30 years old, and the situation is really worse than before. Now we have to repair a lot of damage, because in the meantime, the erosion continued to cancel hard tissue from her mouth. And you can see how hardly she ruined her teeth. And we also have to understand that she had a lot of recessions. So She's very clean. She's brushing with a lot of strength. So the first thing to do was to correct her brushing technique, to try to lower the dentine hypersensitivity, to try to make her understand the importance of a correct alimentation, and to suggest her to see a specialist for her problem. For sure, the solution it was not to perform 20 root canal treatment and 6 porcelain veneers. Also because the porcelain veneers led to a high consumption of lower teeth. As you can see, the lower incisors are really reduced because of the attrition with the new strong porcelain antagonist. So the situation is really worse than before. The patient spent a lot of money, lost the part of 20 vital teeth, and I think this is really not the way to approach this kind of patient. So that's why I'm always saying we should talk to our patients. We should try to understand also what they do not tell to us. So we have to imagine a lot, and we have to verify our suppositions. Etiology, once again, of the erosion, we don't have just the eating disorder. The prevalence will increase because we will have a lot of teenagers consuming more and more and more sodas, more and more energy drinks, and pay less attention to the importance of a non-acid environment in the mouth. So we really have to pay attention to the first sign. We really have to identify this kind of patients when they're really young and before the damage is done. And this is really crucial. This is the message I would like to give you, not just which kind of product or strategy, medical strategy, but try to understand that this is really a huge problem. We can also have another kind of cause for the loss of the hard tissues. The non-carious cervical lesions, they are really common in our patients. The attraction lesions can be the result of the concentration of stress and flexion at the level of the cementum-lamen junction. So the etiology is multifactorial with the possible combination of attrition, abrasion, and erosion too. And as I said, they're really common in our practice. As we said, we can also have dentine hypersensitivity because of us. And this is not a mistake, because we have to treat the periodontal problem, but we have to know before, and we have to tell the patient before, that our treatment can lead to dentine hypersensitivity, even if before the patient was not suffering from this pathology. So let's make some examples. Speaking about the non-surgical period treatment, we can have the simple scaling or the root planing, of course, that can lead to a transitory or maybe to a complete dentine hypersensitivity. And literature says that at 1 week from the treatment, we can have the prevalence of DHS from 53 to 55%. This is 1 in 2 patients suffering from DHS after a simple scaling or root planing. Speaking about surgical periodontal treatment, such as a simple gingivectomy or every kind of flap that you can open, we can have a lot of prevalence. The day after the surgery, we can have it from 77 to 80% of cases. So once again, say it before. And if your patient is already suffering from dentine hypersensitivity, try to reduce it before doing the treatment. Try to make some prophylaxis of the pain. A patient without pain is a happy patient. Just remember, it's easy. So we have to prevent, we have to reduce the loss of enamel caused, for example, by excessive brushing or periodontal disease. We can have 3 levels of prevention. The primary one is the reduction of the risk factors before the occurrence of disease, condition, or injury. We have to understand that it's normal for the patient, should be normal for the patient, to come in our office and to pay us because we have to prevent the problem. Preventing the problem is always best. It's always better than the best solution. So we have to understand that prevention is the future of dentistry. Caring is better than curing. Always remember it. Secondary prevention is the early detection of potential of the development of a disease or condition, or the existence of a disease while the disease is asymptomatic. So we could make the secondary prevention of the GERD, just remember. Or we have the tertiary. Tertiary prevention is the treatment of an existing symptomatic problem, but we have to ameliorate or delay or prevent the progress of this problem. So we have to make a lot of recommendations. The outpatient should reduce the exposure to acid, limiting frequency and duration. You can suggest the use of a straw to avoid this beverage, the acidic beverage, to contact with the teeth. They should avoid acid food and drinks before going to bed. It's really important, even for the children. Do not give the children the juice while they're in the bed, because the acidity and the sugar will stay all night long in their teeth. They should avoid brushing immediately before having acidic food and drinks, because they will remove the film. The biofilm is not just bad. It can be good. The good biofilm is protecting from acidity. And they should also avoid brushing immediately after exposure to acid, such as in regurgitation and vomiting, because they will brush on a surface that is really attacked by the acid. And they should go to the dentist for screening. Screening is really important. We can have a lot of treatment plans, that's for sure, but the diagnosis is just one. So when a patient comes and says, "Oh, doctor, I feel pain when I drink cold water," we just have to remember that dental hypersensitivity is short and sharp, of course, but cannot be ascribed to any other dental defect disease. So our first question is, how much pain lasts after swallowing the water? If the patient says it disappears quickly, then we have to consider dental hypersensitivity in our diagnosis. And the differential diagnosis for dental hypersensitivity should involve caries, of course, pulpitis, dental fractures, the cracked tooth syndrome that is really common, the incongruous or infiltrated previous restoration, invasive dental treatment may be made by another dentist, so we have to ask and to interview our patients, and also, of course, the dental bleaching. We can have, once again, a lot of treatment plans, but remember, I'm repeating, I'm sorry, the diagnosis is one. So we have to talk to our patients, but much more important, we have to listen to what they tell and listen to what they are not telling to us. So we have to look for clinical signs. We have to try to understand what they are hiding from us. Remember, if we have a teenager female patient and we see the sign of the erosion on the palatal side, the palatal surface of the upper teeth, it's not easy that this patient come and say, "Okay, I suffer from bulimia." No, we have to understand it. We have to look for the signs. Do not underestimate VHS and its importance to lead to other pathologies. And so we have to consider VHS in every branch of dentistry. We are perio, we have to focus on VHS. We are prosto, we have to focus on VHS, and so on. So here we are. Polling question number 2. Which of the following diagnostic tools do you routinely use to help diagnose VHS? A, known. B, air blast stimulation alone. C, tactile stimulation alone. D, cold water stimulation alone. E, combination of B to D. So please choose your answer and then click on the submit button. here are the answers. I'm giving mine, submit, so we have to wait. So let's wait for the results. Okay. The poll has ended, so they are just collecting the answers, and they will give us the results in a few seconds. Remember, after the results are showed, you have to click on the participants icon that is in the upper right side of your screen to come back to the other. So the winner is E, the combination of air, tactile, and cold with 73%. Okay, we can switch to the participant icon and we can go on. And you're right, the answer is the correct one. So this is the flow, the workflow of a normal visit for the DHS. We can give our patient a VAS scale. It's really simple to evaluate the pain. We of course have to remember that this is really subjective. So maybe if we have an anxious patient, it will increase a lot of the results. So if he will give high scores, or maybe he will also anticipate the pain. The anticipation of the pain is a common problem when the patient suffers from anxiety. So we have always to be focused on our very patient at the moment. So the air blast stimulation, we take the normal syringe of the chair, and from about 1 centimeter, we can get a short air blast directed to the cervical region of the tooth. It has to be really short. And then we ask the patient to mark a score from 0 to 10. Then, of course, we have the tactile stimulation. So we can take a sharp probe and pass it, scratching on the cervical region. And once again, the patient will have to write a score on the VAS scale. I usually write the highest score of every quadrant in my chart. The last one is the cold water stimulation. We can use a cold syringe to put 1 drop of cold water on the cervical region. And of course, we can help us covering the adjacent teeth with our finger. Then if we see that the patient suffers from dentine hypersensitivity, we have to understand the reason. So if the reason is gingival recession caused by incorrect tooth brushing, we have to teach to the patient how to brush. We have to give the patient a correct brush, correct toothbrush, and take a mirror, and with the hand on his end, we have to teach the correct technique. And this is really important. Most of the time, patients think that pushing hard is the only way to clean. And we also have to teach them how to floss. Flossing is really important. So medium or soft toothbrush, the correct automatic technique, and low pressure. We have to give them the proper toothpaste just because it can be really helpful to immediately relieve the pain. Then some suggestion: avoid cold water while brushing, frequently change the toothbrush, and floss every day. We have to talk. Spending time talking is earning, really. It's really advantage for us. But of course, the patient came to our office with a problem, and we also gave some pain with the test. So with the cold water and cold air blast, we of course created pain. So it's our duty to try to immediately relieve the pain. And immediately after the first visit, we should try to strongly reduce the hypersensitivity with a quick and effective product. So easy to do, with no collateral, with no side effect, and really immediate in result, like the Durafat. So we have a highly filled with fluoride varnish that can easily applied on the cervical region and can easily make the patient more confident in yourself and also in himself. We can also teach a little trick to our patients. They can apply pro-argin toothpaste on the sensitive areas using their fingertips and gently rubbing for about 1 minute to obtain an immediate relief. So we can give them this toothpaste and tell them use it for everyday brushing 3 times per day. But if you have strong dentine hypersensitivity, put some of the toothpaste in your fingertip and make a little massage on the cervical region. And this will help them. We will give them a no expensive, really quick, and no painful at all solution for their problem. And this is really important because you will gain the trust of your patient. So let's have a look at the mechanism of the arginine. It's really easy to understand, and it's based on the polarity. Arginine is attracted to the negatively charged tooth surface, so we can see this animation. So we have minus charge on the surface of the dentine, and arginine is attracted, and this vehiculates the calcium carbonate that can adhere to the dentine surface. This provides a protective seal over the surface of dentine. So let's have a look to this study. As you can see in this draw here, we have simplified the message that the quality of life can increase during the weeks as much as the pain decrease. So a lot of pain for normal life stuff, maybe just having an ice cream with friends can be really painful. And this, of course, is a problem for the quality of life. If you can treat this kind of problem with so simple solutions, you can really turn the quality of life of the patient, and they will thank you. Because without asking for very strong treatment plan, very expensive treatment plan, but just teaching and suggesting the right product to use, you will for sure improve their quality of life. So the Colgate Sensitive Pro Relief toothpaste, it's really useful because we can have long-lasting sensitivity pain relief from the very first use. In particular, if we teach the trick of the fingertips, this is really important. So we also have a good taste, so we can have better compliance even from the youngest patient. And of course, don't forget about the 1450 ppm fluoride that is really important for caries protection. So do not focus just on DHS, of course. DHS, as we said, is really important in every branch of dentistry. So, of course, after the treatment, we gave the Durafat varnish, we gave the toothpaste, we gave the correct brushing technique. We have to control the patient. Because if the patient comes back with the pain, a lot of pain, and maybe it's even worse, we have to reconsider the diagnosis. Maybe we do not have just dentine hypersensitivity. Maybe we have caries or whatever. So we have to, once again, talk and listen. We have to ask for changing symptoms. We have to repeat the test, the same test, and compare the results. And then we can maybe adjust the therapy or just give a maintenance therapy that is really, really important. So summarizing, we have to identify etiology and predisposing factors and remove all the predisposing factors that we can remove. Then we have to work in teamwork. Dentists and dental hygienists are really a teamwork where the top player is the patient. So this is really important to understand. And we have to give great importance to topical agents because they are not aggressive, they're not expensive, and they're really useful. we have to be careful. The patient must not feel pain during our maneuvers. So be careful. Of course, in the test, we have to use the cold water, but avoid cold water in all the other maneuvers that you're doing. And then remember that these patients are scared. They are really scared to feel pain, and maybe they have the phenomenon of the anticipation of the pain. And of course, once again, the message is talking is mandatory. Always interview your patients. Always try to understand if there is something they're not telling you. So remember, if the patient is happy, we are happy. We have less problems. And so we are at the end of the lecture. So there will be a Q&A session. And let me already thank you for the attention and thank once again all the Colgate team for the big support in preparing this webinar. And so let's Nikki to introduce the Q&A session.
Thank you, Julio. That was a really good presentation. I found it very informative. So, yeah, very good. Thank you. We have had a few questions throughout the presentation. Yep. So I think we've got about 10 minutes just to answer a couple before we wrap up. Great. So the first question we have, it says, you have shared a number of strategies to help the DHS patient, including improving their quality of life. Do you specifically promote your practice to attract DHS patients? And do you see DHS as a practice builder?
Oh, yes, of course. Of course, because you are having a lot of results with a so little effort. Just remember, making the correct diagnosis is our duty, so we're doctors. But giving relief, immediate relief, with a so easy therapy. I mean, giving a toothpaste sample, a toothbrush, teaching how to use them, and the trick of the fingertip, a little layer of Durafat varnish, and you can really release the pain of your patient. So the patient will trust in you, and maybe he will send you a lot of friends, relatives. So, of course, it's really important for our practice. And I strongly believe it. And I'm making the test for dentine hypersensitivity almost every time that I'm doing the first visit to a patient.
Excellent. Thank you. So the next question I've got is, patients are keeping their teeth for longer. So as you say, it is inevitable that DHS cases will increase in the future.
Yeah.
I agree we have to start thinking and acting differently, but what is the one thing we can do differently from tomorrow?
Oh, this is a good question. I'm talking about the Italian environment. I don't know if it's the same in UK, but I think we for first, as clinicians, we have to contribute to this phenomenon, to the maintenance of teeth. So the method is try to maintain your patient teeth instead of replacing them with implants. So once we said this, considering that we are going to face older people with almost every tooth in the mouth, we have to save the structure that is left. So try to not to be aggressive. Try to be additive in our practice. Try not to prepare the teeth. Try to add resin. We have adhesive dentistry that is amazing today. And so we can try to solve the eventual pain that we have with treating the dentine hypersensitivity and not making a lot of root canal treatments and then prosthesis.
Excellent. Thank you. Very good answer. The next one we've got is, I like the idea of advising patients of the potential risk of DHS when explaining a treatment plan. Have you had patients decline treatments because of this risk? And if so, what did you do?
Oh, actually, maybe the only the only occasion when I can have this kind of problem is for bleaching. I mean, bleaching, of course, is only aesthetic. It's not a medical treatment. So maybe if a patient comes asking just for bleaching, I mean, most of the time we have to make the patient understand that maybe bleaching is last of his problem. Maybe the real problem is oral hygiene, caries, or whatever, but they are just talking about white teeth. Once we said this, I always say, pay attention. Maybe you will have dentine hypersensitivity. But I suddenly say, if you're already suffering from dentine hypersensitivity, we can make a sort of prophylaxis of the pain. So I try from the very first visit to give the proargine toothpaste and so on. And then, of course, we will try to use a low percentage of peroxide and a slow bleaching treatment. But yes, can happen if the patient is really afraid, maybe they can refuse the treatment plan. But also if they understand that bleaching is just for aesthetic and it's not for healthy reasons.
Excellent, thank you. Another one we've got is, and actually we've had a couple of people who've asked this question actually, it's around to help build patient confidence in a known DHS patient, would you recommend applying proargine toothpaste to teeth before starting a treatment? And somebody said, with hygienists pre-scaling, would you recommend, would you recommend it?
Yes, of course. It's not something that I do every time, but if I see that the patient, or if the patient tells by himself that he's really suffering from DHS, of course, I'm not taking the scaler and not trying to make things worse in the first visit. At first, I try to relieve the pain. So once again, it's a sort of prophylaxis of the DHS, trying to prevent the pain. And I think it's the best way to gain the trust of the patient. The patient will be really more confident in us. And so I strongly believe this is really important because patients hate dentists. Let's say it directly. Sometimes they come to the office and they say, "Good morning, I hate you." So if we make them, they feel pain for simple things like a simple oral hygiene, we all know that they can feel pain. This is not helping. We should try every time to cancel all the useless pain, because the useful pain, okay, is useful. It's the sign of a problem, but all the useless pain, as the word says, is really useful. Useless, I'm sorry.
Thank you. And I think we've got time just for a couple more. Someone has said that a dentist I work with spoke to patients who have hypersensitivity about lowering their intake of fruit. Would you recommend this?
Lowering, I'm sorry?
Of lowering, so reducing the amount of how often they have fruit, because that was causing their sensitivity. Would you recommend reducing their levels of fruit intake?
The fruit. Maybe if the intake of fruit is really high and with a lot of acidic fruit, maybe if the bad habit of the patient is to always have a slice of lemon, I would say, okay, reduce it. It's really important to reduce it. If it's just normal consumption, maybe I will just to try to add some strategy to prevent the damage. So the toothpaste and some product contrasting acidity. We always have to make difference between a good habit that can have some side effects and a real bad habit, like chewing all the day something like lemon.
Excellent, thank you. And I think we've just got one last question, which is, would you say that eating disorders are manifested on upper teeth rather than lower teeth?
Yeah.
From what you've seen?
eating disorders, in most of cases, of course, this is not a rule, but it's in most of cases, the erosion is focused on the upper teeth because the tongue is kind of protecting the lower ones. So it's really helpful to differentiate between erosion caused by eating disorders and from other kind of disorder. Maybe, as we said a couple minutes ago, the patient that is chewing every day, all day, a slice of lemon will have the erosion on the buccal side of both upper and lower teeth. So we always have to think, why do we have this problem? Just to try to understand the reason behind. I think this is really crucial, really, really important.
Excellent. Thank you so much, Julia. I think that's all we've got time for this evening. So really informative presentation and great questions from everybody. So thank you. So just as a reminder, so don't forget that you will be sent the survey. You'll be sent an email after the webinar, which will include a link to the survey. The survey will also pop up when you close the screen for the webinar, and you need to complete this in order to get your 1 hour verifiable CPD for UK participants. And if you were one of the first 250 people, then you will also receive your free proclinical electric toothbrush, but you need to complete the survey. The certificate will be sent to you within 2 weeks of completing the survey. And if you qualify, the toothbrush will be sent to your chosen address within 28 days. So thank you once again, Giulio, for a really great presentation. And thank you, everyone, for joining us this evening.
Thank you, everybody.
Thank you. Good night.